All right, I can see we have a bunch of people online, so welcome everybody online to our Kenya Research Training Center seminar, which we have weekly, and you're always more than welcome to come. And today, two students who are very busy staring at their screens are going to talk to us about what they did last summer.
Do you want to talk about Merrueshi, the project?
They're going to give all this background.
Okay,
Okay, here
great.
comes Sarah Masuko. Do a little intro, Sarah. Do you want to say a quick hello?
Hi everyone, I'm Sarah Masuko.
Is chair open?
I'm Sarah Masuko. I'm an assistant professor in the Department of Global WACh, and happy to be here today.
Great. And nice to see Monisha and Allison. I saw Scott on there.
I'm gonna just ask for, I'm going to try and join on my laptop so I can admit people and not be distracted here,
okay.
but I just ask for your patience.
Okay,
Because this
we can
is
just
not
wait
my
for-
normal, job, but, so.
Maybe we could just, before we dive into the formal presentation, do you just want to give a little background for some of the students who might be listening about how you heard about the program or learned about it?
Recording in progress.
Something like that would happen. You heard about it first, I think.
Yeah, I
Yes.
did. So I saw it on the blog, the Global Health blog, and they were looking for 2 students or any student that would like to go to Merrueshi, that's a Maasai village in Kenya, to work with the community on any project of your choice. So it was open, and I really wanted to get the rural experience. So I reached out to Carrie, and the rest is history.
I think one of the travel grants. So.
Oh yeah,
Fast, I remember you didn't have a lot of time.
yeah,
Successful in applying for one of the travel grants.
yeah, I did
Tell
apply.
others, now's the time to tell other students.
Oh yeah,
And
yeah.
then Tara, you came on even a little after.
Yeah, I also found it on the Student Opportunities blog and just thought I would reach out. And at the time, wasn't planning on using it as my practicum, but was very much interested in kind of capacities, assets, and needs assessments, and field work, mixed methods field work. And so kind of hopped onto the project and met Iffy and met with Carrie, and yeah, the rest is history.
You both ended up using practice.
Yes.
Just doing different aspects. Okay, are we set to
Yes, I think so.
dive in?
Okay. Okay. Hello, everyone. This is my script. Hello, everyone. Good afternoon.
Are we recording?
We are recording, but we're not seeing the
Oh,
slides.
wait, what's wrong with it?
Sorry.
It's back.
Okay.
Okay, and welcome to our presentation titled Capacities, Assets, and Needs Assessment of the Merrueshi Clinic, if you would, Merrueshi Village. My name is Ifunanya Azie, like I mentioned earlier. With me is Tara McCoy. We're both MPH students in the Department of Global Health. Together, we lived and worked in Maasai land over the summer through the supervision of Dr. Carrie Fakwa, who is here with us today, and the partial financial support from the Global Health Travel Grant. Before we start, we want to acknowledge the intersection of our personalities, which reflects on how we view the world and the work that we've done. This understanding helped us challenge our biases throughout our involvement in this work, and even beyond as we continue to share our learnings with the world. It would be great to call out that the data and the stories you will hear today are not just data, neither are they just stories. They represent real people and their lived experiences, which we all have a duty to either empathize with or contribute to without any form of tokenism.
Quite a bit, so sorry.
Okay, here we go.
So our objectives were to assess the needs, capacities, and assets of the Merrueshi community, Maasai land, Kenya, to evaluate the teenage empowerment program of the Maasai Association, and to assist the Maasai Association to efficiently plan and maintain current programs through recommendation based on findings from our assessment. So to lay the foundation for this presentation, it would be worthwhile to quickly run through some background context. Our work centered on 2 locations, the Merrueshi village pictured on the slide, which is one of the Maasai tribes in Kajiado County in Kenya. The village is sparsely populated, contributing to Kajiado County's there are about 1.2 million people as of the last census in 2019. Our work centered under the umbrella of the Maasai Association, a nonprofit based in Merrueshi village and registered also here in Bellevue, Washington State. Their primary goal, they have two goals, education and economic development. It's also worth noting that the Maasai tribes are predominantly semi-nomadic people. They typically move towards where they can find food and water for their cattle herds. The clinic is in the Merrueshi village. It serves people living in approximately 28-kilometer radius around the village. It was also built by the Maasai Association. These services are funded by private donations and patient copay generated by drug markups.
And the population of Merrueshi is not 2 million, right? It's a few thousand.
Yeah, a few thousand. The other one is the Kajiado
County, which actually abuts
Yeah.
Nairobi.
Yeah, I wasn't able to get the actual number for the Merrueshi community, but it's very sparsely village. So these are the projects that are being run by the Maasai Association. They built the village clinic, the high school and the primary school, but now the government now controls the high school and the primary school, but they contribute towards some part of funding for the students in the school. Then they have like a goats and cow project program where they let donors through the website contribute some money towards funding, like giving the villager a goat or a cow. Then they have the water hole restoration project, which we saw when we went to Merrueshi. And perhaps the most, like the very good one is the Maasai Simba camp, because that brings economic, economic provisions to the community. So they provide eco-friendly paid lodging for tourists. That's where we stayed while we were there. They organize like, camps or tours to the call. Like the Amboseli kind of lodging thing. So next slide, please. So just other context is that these are the services that the clinic offers. They offer the outpatient unit. They have the MSCH, which consists of the ANC, the maternity services, and the child welfare clinic. They also have like a nutritional service unit. Then they have the lab services, which is like a very small room where they run all the lab tests. Then they have the pharmacy, even though they don't have a pharmacist, but they have like a small pharmacy shop where they get the drugs out to give to patients. Then they have the mobile clinic and the ambulance services. I think I'll hand over to Tara at this point.
And then just a quick note on the antenatal care and the child welfare clinic. Usually every week they have their antenatal care clinic on Thursday, and then their child welfare clinic is on Wednesdays. And so that's just supposed to be a time where like a scheduled time where mothers know they can come on Thursdays and they can be seen. But then to kind of get into some of our methodology, so we used a mixed methods approach for the assessment. The quantitative data was sourced from clinic registries. Data at the clinic is not entered electronically, so we spent a lot of time inputting the data into Excel sheets for quantitative analysis and visualization in both R and Excel. And for the qualitative component, we conducted key informant interviews with clinic staff, which the clinic staff currently, there are 2 nurses, 1 clinical officer, a secretary, and 3 support staff. So we were able to interview them. We conducted focus group discussions with antenatal and postnatal mothers attending the clinic, and then focus group discussions with children at the primary school and the secondary school. And that third bullet point is getting towards kind of our second objective, which was to evaluate and learn more about that teenage empowerment program. Okay. So for the quantitative portion here, I want to go over some of our data sources before I get into showing some of the data, but we gathered our data from 5 clinic registries: the maternity services register, the ANC register, the outpatient summaries for over 5 and under 5, and then the monthly workload summary. These are not all of the registries at the clinic, but like for example, there is an immunization registry. It is a bit incomplete and hard to track because there's no kind of unique identifier that tracks a child along their immunizations. And so it was a bit difficult to track any of that. And since we were there for about a month and also needed to do qualitative data collection, we had a discussion with the nursing staff to kind of determine which data would be most helpful to kind of transfer into an electronic format for analysis. And that's how we kind of came into the maternity and ANC, because that kind of makes up the the bread and butter of what the clinic does. We did kind of later on decide to add in the outpatient summaries and the monthly workload summaries. They are summaries, so they don't get into some of the more granular data of like the patient's particular age, but they do allow us to kind of look at patient counts, diagnosed conditions, and get some of those broader trends in data. So we did decide to put those in as well. For maternity and ANC, we have the data from July 2020 to July 2023. And then for the outpatient summaries and the monthly workload summaries, we have the data from October 2020 to October 2023. And before, again, showing some of the graphs, I want to kind of situate us in the kind of geographic landscape of the clinic. So Merrueshi is located in that little red circle. Again, like if you said, this is Kajiado County, and Merrueshi is located in Kajiado East sub-county, but the clinic doesn't just serve the people in Merrueshi, it serves kind of villages, or people come from villages all over Kajiado East and Kajiado South sub-counties, which are kind of denoted there. I kind of put some of the more common villages where people are coming from: Isar, Mboko, Ulanti, Simba Cement. Simba Cement is, there's kind of a new cement factory that's kind of popped up next to Merrueshi, and this kind of like village is essentially developed around it. And while there is a clinic, it's pretty sparsely resourced, and so a lot of people come to the Merrueshi clinic, and so that's kind of, you kind of seen an increase in patients over the years. And then Lloyd Tuk Tuk, which is right here, is where patients will get referred if they need an ultrasound or if they need a C-section. That's where they're referred. The clinic doesn't handle those cases, and that's about 30 kilometers away.
So in that area, is that the catchment area for the clinic, or is that a wider geographic area than the catchment area?
It's wider.
It's
Yeah,
wider.
that's wider. Yeah, sorry, it doesn't, I was having trouble finding like a graph that like showed what I wanted and then also doing, so this is all Kajiado County. Kajiado East is kind of like through here, and then like this is Kajiado South, so it's kind of this portion.
And are there other primary care clinics located located in the area of where you just pointed out on the map? Or is this the only primary care clinic?
So there's the one that's in Lloyd Tuk Tuk, which is like more of a larger medical facility, and then there's one up in Amali, which is going up that same road. But I think, as I understand, Merrueshi is the primary clinic. Again, there's one in Simba, which they tried to like stand up, but it doesn't receive the necessary resourcing or staffing to kind of be a viable option for folks.
And those other clinics, they're public or private?
They are public. Yeah, they are run by the county, the Kajiado County. And they also like assist, I'll talk about that later, they assist the clinic partially in some areas.
And this one is technically private.
Private,
right?
yeah.
It's all funded by Maasai Association and donations and
Yeah.
money that can come in through some of these other avenues. Right. So they don't charge, but you'll probably get
Yeah.
into that.
I'm curious about the registration in Bellevue. You mentioned that it's registered in Bellevue.
Yeah.
Oh, the association.
Association.
It's an NGO.
It's an
Yeah,
NGO.
share the list.
I just said like the founder went to UW, so,
Okay.
yeah,
Okay.
yeah,
All right.
so, you know, the connection.
And he grew up in Merrueshi
Okay, gotcha.
and came over here to do this. It's
That's
well,
helpful.
I can tell you
It's
the whole.
helpful. That's
there's
really
a
helpful
lot of story.
background information though.
Okay, so now I'm gonna just kind of go over the ANC, the maternity, some of that family planning, outpatient data. They're just kind of like broad to kind of give you the sense of the like patients or the numbers of patients that they're seeing, the kinds of services they're providing, and some of the characteristics. So for antenatal services, again, they hold a clinic every Thursday for pregnant women. So from July 2020 to July 2023, they had a total of 2,697 total ANC visits, with an average of about 71 per month. In terms of the women, I will just preface this graph, this one with kind of similar with the immunization, there isn't necessarily a unique identifier for women coming to the clinic. And so they can kind of track, but they have booklets that they use, and so that's not necessarily translated into the register. So just a note on this is that, for example, if a woman went to 5 ANC visits and was aged 23, she'd be counted 5 times towards this graph. So this graph, there are severe limitations, but just to give an idea, yeah, the majority of patients coming in are 20 to 29 for the ANC visits. And then the next kind of grouping, the 12 to 19, followed by 30 to 39, with an average age of about 24. Getting into maternity. So for maternity between July 2020 and 2023, the clinic had 964 deliveries for an average of about 25 per month. I think it's important to note here that again, the clinical officer is trained to do deliveries, but primarily focuses on outpatient, and so largely the deliveries are conducted by the 2 nurses, and the clinic is open 24/7, and so those 2 nurses are keeping the clinic up and running 24/7, and so these 25 births per month are not necessarily like one on Monday and one on Tuesday, one on Wednesday. But there were several instances in the registry where there were 3 to 4 women giving birth kind of at the same time and being handled by the 1 nurse on duty. And the 1 nurse on duty maybe being supported by the support staff who not only cook and clean, but sometimes act as an assist during a delivery. Okay. Of these 964 deliveries, 98% of them resulted in live birth, 2% in stillbirth, and throughout that time, there were only 2 maternal deaths reported. In terms of some of the characteristics of the women, similar average ages, average age is 24, and like shifting between screens. Majority of women giving birth at the clinic, 80% are married, 18% are single, and the kind of remaining 2% are divorced, separated, widowed, or there just wasn't any information about their age. On average, women came in for 3 to 4 ANC visits before their delivery. So looking here, 60% of women coming in are 20 to 29, 20% are 12 to 19, and then 30 to 39 or 17.5% are in that 30 to 39 age range.
Do you have a further breakdown of the younger?
I have it for the report, but since we have a lot of qualitative data, we were trying to kind of condense some of our quantitative, but I can definitely provide that afterwards for folks that are interested. All right, so for family planning, this is kind of just showing new and returning family planning recipients. I think the big thing to note here is this gap from December 2021 to July 2022, where there is no family planning or where there are no family planning recipients. After discussing with nursing staff, this is largely due to stockouts. They just weren't receiving the methods anymore. And then after they continued, you'll see like from April 2023 on, it's fairly low. It was kind of stock issues and also, according to the staff, very low demand for family planning methods.
Suddenly things just shifted. Maybe there was demand and suddenly there's not.
Well, it's not surprising after a stock out.
Yeah,
That
right.
you have to have a decrease in demand,
But it's funny, if you look at the graphs, all of them in 2023, they are less than
Yeah.
Far
the
less.
years before.
Yeah, there are many reasons. I'll talk about that when we
In
get
that
to the
qualitative. And in terms of methods, the overwhelming majority of people that were coming in were getting injections, and we'll talk more about this, but this is kind of largely due to the inconspicuous nature of them and that their husbands don't know that they got them, whereas the pill or the implant, that can be easily detected. So there's kind of like a degree of, I don't want to say anonymity, but they can do it and nobody will know.
Just curious, like, why there's no IUD?
I don't think they provide IUD, but since we're not sure, we can
Yeah, we
cross-check
can
on that.
cross-check with the
But this is what.
In terms of outpatient, just average number of patients over 5 per month and average number under 5 per month. I think the big thing to note here, well, first, the majority of patients coming in are over 5, but you see a steady increase from 2020 to 2023. for both over 5 and under 5. That could be just returning to pre-pandemic levels. We are planning to kind of like look at the last time students were in Merrueshi was in 2019, and then prior in 2018, 2017. And so we can kind of look and see what that patient load was like. And so that's kind of our plan, is to also look at that and see if this is returning, or if this is just maybe it's increase in patients because Maasai or the cement place is there, or maybe people know more about the services. And so like there are more people needing to access the services. But again, patient loads are increasing, and it's 2 nursing staff and 1 clinic officer seeing these patients. In terms of the burden of disease for outpatient over 5, it's for both outpatient over 5 and outpatient under 5. Upper respiratory tract infections make up the majority of conditions coming in. This other conditions category is kind of a catch-all. If somebody came in for like symptoms that couldn't necessarily be diagnosed into something specific, it goes into other. Talking with Nurse Rachel, that could also be sometimes schizophrenia gets classified as under other conditions. So it's kind of a catch-all, but then looking at pneumonia, UTI, amoebiasis, other injuries. Road injuries are on there, but other injuries, they get lots of injuries from the cement factory as well that come in. And we'll talk about the upper respiratory tract infections when we get into the qualitative as well.
The bites. It's like
Oh yeah, the bites. Bites from snakes, a couple of cases of bites from lions, dogs.
Yeah,
Come in.
Yeah, because they're Maasai.
they're Maasai, they're like,
They're
they live with the animals.
They're out.
And then for under 5, again, upper respiratory tract infections, kind of beat them all, followed by pneumonia, gastroenteritis, tonsillitis, and diarrhea. So now we'll kind of transition into the qualitative, which will kind of help contextualize some of these scripts.
Yes, I hope I do justice to it, but just draw me back if you need me to clarify anything, and also for the sake of time, I'll try to be a bit quicker. So we had, like we mentioned earlier, we had key informant interviews and 2 focus group discussions in different sessions. For the key informant interview, we interviewed 5, 4 were clinical, like the staff, 2 nurses, 1 clinical officer, and the admin person. We were not able to speak to the lab person because she was on leave at the time we were there. Then the support staff, usually they do like the cleaning and the cooking for the pregnant women in the ward. Then, so for the focus discussions for the clinic based, we talked to about 20 women in 3 sessions. We had women as young as 16, and we had like the mean age was about 25, and they had like 3 to 4 or 5 children. Then we had 2 discussions trying to evaluate the teenage empowerment program. So we had like 30 pupils in total, 15 from the primary school and 15 in 2 sessions with the secondary or the high school. And these 2 schools are all within the Merrueshi community, but they are boarding schools. So the reason why they are boarding schools is because the Maasai people, like I mentioned earlier, are semi-nomadic. They move to where they can get their food, or, like for the cattle. So if you don't have a boarding school, it's very hard to retain the children in school. So speaking with the clinic staff, the one thing we really saw was the sense of commitment with the clinic staff. I haven't seen that anywhere in my life. It was really amazing to see how very committed, all of them consistently. It wasn't like what they were saying to us. We could see that even from when we spoke to the women. They feel a sense of commitment giving back to the rural community because they are underserved, but also because they are able to learn a lot of skills, because if they work in the town, which is like in Nairobi, they're not really able to like do all the things that they're able to do in the village. Because of course, like a clinical officer is below the medical officer, so you're not like an errand person to the medical officer if you are in the township area. So they were really very satisfied, that's the clinic staff, with the clinic's ability to provide subsidized treatment and generate some money to purchase medication. So there's the thing called the Mama Linda, which the Kenyan government provides some money to the clinics, the clinic or the medical facility when the woman gives birth, so they give birth for free. But they also provide other things for free, but they charge as per how you can afford, like pay as you are able to. So most of the income they make is through like the drug markup from the pharmacy. Some challenges that we noticed and also from what we heard, most of them, like example would be the nurse. She's been there for about 9 years and her salary has been the same. And you know that there's inflation in Kenya right now, everybody's really struggling. And it's like, I mean, that's one challenge that they're facing right now, the salary issues. Then there's also the staffing, like we mentioned, like Tara mentioned that sometimes they have about 4 to 5 deliveries in a day and it has to be like one nurse or one support staff assistant. Then there are also some inefficiencies in the communication. Major sin ailments are usually like the respiratory infection. I didn't put that picture here, but there's something called the manyata, like a very small hut without windows most times. We actually like visited the manyatas. That's where the women stay, like that's where they live. So because it's really enclosed, they have issues like TB coming up from the and also UTI, ROTI infections from those places. And the village hasn't seen rain in 3 years or 4. Yeah. So that means that they have to walk very far distance to get water. And that also means that, the hygiene will not be, perfect. There's also anemia in mothers. There's really poverty, like because there's no much food around. I think they have food, cabbage and stuff, but there's anemia in mothers because they have to really like trek far distance. They're not really eating well. The major needs currently right now, which the reason why we're also sharing this, if you're touching your heart to help, there's a need for ultrasound machine. They send the women out to like Tok, which Tara showed on the map, which is about like 28 kilometers away from the center to get ultrasound like check. And most times they don't really go to get them because so many factors, right? That's one thing that is really needed in the clinic. Then they have baby warmer. I was also supposed to put that picture up, but I just didn't find where to put that. When the babies give birth, they put them in the cot, and it's really like an open room, and the windows are open, mostly spoiled. And then they put like a small light, which is really not good for the baby. So that's what they have need for baby warmer. They have need for PPEs for infection control, very, very needed. And the other things that I put there, window repair. And while we were there, the women would come and they would stand under the tree for hours waiting for their turn. Sometimes they will sit on the like the slab, the cement slab, and they have babies tied to their back, which is really not, good. We even had to like build a chair for them before we left, but it's not still enough for the mothers. So we kind of highlighted this thing because it came out a lot. So it took about a year to get the weighing scale. Not getting these needs are demoralizing. It makes work tedious and a feeling of being unappreciated. There is also no communication whatsoever. The association is doing really well, building all of this and, trying to better the lives of women and children in the community, but there's also a lag in the communication. The last time we were there, they hadn't had a meeting in 4 years with their director, which is really, with the leadership, which is not really, it's not really helping them in terms of their passion and commitment to keep doing the work. Because they could also like find job elsewhere, so but that's a problem. So for the mothers, most of them had very little education or even like no formal education at all. There's issue of early marriage in the community, but the mothers we spoke to were between 16 to 23 years, minimum and maximum, and they were really mostly housewives. They don't do anything. Most of them have like small duka moja. It's like duka moja, like a small shop where they sell like petty things, And interestingly, I wouldn't say that they have so many children, like 10, 12, but like maybe minimum is 2 and then 5 children, Then
In terms of the education, the schools, because you did mention there were schools, those only started a decade ago, so most of these mothers would not have benefited from them.
But the mothers are also really young. Like we have mothers of 16 years.
They drop out of school.
Yeah.
Because they get married.
It's now changing.
When they get married, they drop out of school.
Yeah. But I believe from what we saw, it's changing. That nurse is doing amazing. She's on this call. Let her speak. when we get to, but they're doing amazing with the health education, especially to the fathers, because they're like the gatekeepers. So
There's a big push to have the girls in school.
Yes, the keeping girls in school.
Yeah.
There's a national program. Keeping girls in school.
But you're saying there's not even really much primary education.
Yeah, for the mothers, like we had to like find people who translate what we're saying, because most of them could not. Yeah, and we asked them.
That's my point is that I think fast forward.
Yeah.
10 years or 5 years.
The schools
now
were
the
not
girls
there.
are able to be in school.
Yeah.
This is my open understanding, because there's more access to water and they can actually attend school instead of having to, the water.
Then for the culture and health, this kind of helps us to put in perspective what we saw in the data. Low maternal autonomy is a big thing. Like we had, so from this, you can see the picture there, we had some mothers at that side were kind of older mothers, and they were able to tell us like the issue they have with like in the communities, as well as the younger mothers. So for the family planning uptake, there have been issues where the fathers have to like, the spouse has to like drag the woman back after beating her to come and remove that implant. Like they bring them back to the clinic and say, put that thing off. Yeah, like don't bring the Western culture to us and stuff. So that's why they have to hide and go take the injections. But also, I think they've been trying to push out health education. It's a gradual process, but that's lack of maternal autonomy. The way the Maasai is structured is that the women stay home, but they build the houses like the Manyata. The women build those houses. They go to get water. They feed them, like they go to get food, and they also walk like long distance to get those things. And that's why they have issues like back pain, chest pain, and mostly the flu is because of the terrain of the environment. They also have like more facility births now. So we spoke to the older women who said they had most of their maybe 2 to 3 kids at home when it was still a big, like a thing to have babies at home. So I will say that the policies, but also the clinic is at a very vital point in that community. And they've been very instrumental pushing out health education, come to the clinic and give birth. Sometimes they use their ambulance, like the car, to go get the mothers when they're really due, to bring them into the clinic to have their babies. So we've seen like a spike in facility births lately. And there's a myth that goes around that, when the mother have given birth, you're not supposed to sleep with her for about 1 year. So the men believe it, and the women, because of that, they don't like have any intimacy after like 1 year, going into 2 years of the marriage. And also like the men also have like many other wives. So yeah, I think that because we were wondering why, even though yes, they're not taking the family planning, but they don't really have so many children, So when we asked them, they say, oh yeah, our husbands don't touch us. It's like a cultural thing that they feel like it's a crime or something or they're going to die when they sleep with us. So then when we evaluated,
Somebody did some really good,
I found that I was like, oh God, that kind of, yeah. I would say that honestly, like myself and Tara, thank God I was with Tara, because it was a very depressing moment. That sometimes we'll be fuming. Like, I don't understand why these women, they do a lot, yet they get very little opportunities, to better themselves. The women scored the clinic very high, like all of them. They mentioned because of like the way they attend to them, they don't like to go to any other place. The quality care, especially like when they come pregnant, they give them 1 birth and then they give them free food. So that's one thing that they really scored for. Other things that they need are on the screen, the bed nets. They provide bed nets in the public facility, but they don't give out in the private. So that's why they don't have bed nets. And they also don't have maternity wears. The ultrasound was really, like the women really said they really wanted that ultrasound because they're not really able to trick that far to like talk to be able to get the ultrasound done. And they have to rely mostly on their spouses. Like if they have like the motorbike. So they have to rely on the men to bring them to the clinic. But if you're not in good terms with your spouse, you're gonna trek, baby, you know? So they trek like long distance to get to the clinic, to get to anything they have to do because they don't really have the money to get that done. Sometimes if they have good spouse, they have to like, beg for the money or ask for the money. Then on the next slide, one of the issues they had was the issue that like they were lacking limited services in the clinic. So aside from the MSH and the outpatient, like few other things they do, they're not able to like get other treatment, so they have to go to the county, which is like talk. So I'll quickly talk about the empowerment program and then we wrap it up. For the high school, we spoke to them. One thing we found that is the nurse is the one who does the outreach and coupled with every other thing she has to do on top of vaccinations. So she's not able to go all the time. But the issue with this high school is that the government pays some part of the fees, the association pays some part of the fee, but there are still some copay left. So, but they let the kids stay in school, but they will not get their papers when they are done. So that means that if they don't pay up, they're still not able to work without those papers. So they really asked us to help them to see ways that they can pay up those school fees. Then they have social media pressures, and of course there's an issue of drug use in the community, especially with the climate change happened. They lost their cattle and their cows and things like that. Then there's lack of counseling services. The female are lacking pads and hygiene equipment, materials like soap, and they don't have like good reporting channel to report things like sexual harassment and sexual abuse in the community. Same with the primary school. They had a lot of questions around like, what do we do like when you're pregnant? Who do we talk to? How do we know about our menstruation? The circle, because they're not really being taught about those things in school. And the nurse goes there as often as she's able to. Next slide. Yeah, so we're trying to track the healthcare seeking pattern. I think we saw this in the class yesterday from the donor. We try to track this. We noticed that most of them go to the chemist first. Like that's the first point of action. And that's because the chemist is like, it's very close by. And because, like they have to walk so far to the clinic. So they seek that chemist first. Then they go to the traditional medicine and the clinic facility as a second option, depending on if the sickness continues. Then on the last CADA is the home remedies, they seek solution from elderly mothers, and the clinic village, if they cannot treat, then they refer to the county clinics. It's also like very important to track this because you would know where to give the health education, like what to target, who to speak to.
Sorry, so what's the difference between the clinic facility and the Merrueshi clinic in this case? It's the same.
Yeah, it's the same in this case, yeah. But I try to put that just to show that the facilities, the village, the clinic. So I'll talk about the assets and the capacities here quickly, but the needs will tie that into our recommendation also, like to save time. So there are some partners that go to the clinic to help them to do things like data entry or to collect what they've done or to just give them resources like the Red Cross. There's this one for family HIV. So those are very good partners. We were thinking, I think also Dr. Kari suggested that if we are able to get secondary school children and train them to be able to do data entry, then we're able to solve two problems. The kids are learning, at the same time, they're solving a problem that the clinic really needs. They need a support staff for data entry because the data is really subpar. I mean, it's not, they have to do a lot, so coupled with entering data. Then the women organizations are very strong, even though they are below the men, but they're able to give out loans sometimes. They're also able to help solve some small conflicts in the family, in the village. The church is a very vital place because when they want to do like health, like big vaccination, while we were there, they were doing the polio and the cholera. Yeah, and we also like joined them. The church was like we are going to the churches and they gathered so many people in the village to be able to do those vaccinations. Secondary school, yeah, we put this here because we were thinking about getting those students to be able to learn, but also serving a need in the clinic by helping with data analysis and the data entry. For capacity, we saw that there's a good sense of community. sometimes the women can, they feel they don't know what else to do. Like, for instance, was the family planning thing where one woman she was like, when my husband promised the clinic and removed the implant, I was like, you know what, I'll give birth until my last egg. So even though there's a sense of commitment, I'm not sure how empowered they are to be able to stand up for themselves. And yeah, there's a passion, there's a commitment from the clinic staff. And we're thinking about the alumni and the diaspora network, because I believe that if we strengthen this area, they'll be able to help us, like, take off some copay from the school fees from the students, even help to, because it can't only be on one person. So I feel like the diaspora network will be a very good place to, if they're able to pull the resources from the alumni community, some of the issues in the villages can be solved. Sarah, I'll hand over to you to quickly round up.
So we're going to kind of highlight just 4 of the main challenges that, and the report will have more of them, but we wanted to highlight like these top 4 and what we felt like came out as kind of the big ones. But first, the challenge of communication between the clinic and the Maasai Association. And just to highlight, or going back to Iffy's point about not having the meeting in the 4 years, I mean, there was the pandemic going on and the recovery and trying to like reinstitute processes, but the real need to kind of streamline and regularize communication between the clinic and the Maasai Association by instituting regular meetings and having kind of like a regular point of contact or some kind of regular communication channel, just so that the clinic can communicate their needs and the Maasai Association can also communicate kind of where they're at and their abilities to provide services or funding. The next challenge is data entry. Like if you said again, I mean, 2 clinic staff or 2 nurses and 1 clinical officer, data entry is probably like the last thing on their mind when they're taking care of these like massive amounts of patients. But it is very important, especially for advocating on behalf of the clinic and for kind of communicating needs. And so here we say hire additional staff member. We know that that's very difficult, but also considering partnering with the secondary school, so that way students kind of get an idea of what it's like in the medical field or kind of in this kind of clinical environment, and we're also satisfying that need for data entry and better data entry and management. I think the understaffing is probably the one that we ran into as probably the most severe. I think every clinic staff member mentioned that just having an extra nurse would do so much, because again, they're 24/7, and so somebody is always on the clock. And so, I mean, as we stated, one of the big capacities of this clinic and something that I think came out a lot in the focus group discussions is, women feel like they're really cared for at this clinic. Like the clinic staff really make them feel like they're valued, they're cared for, and they're given quality care. And it's that passion and that compassion. But passion can only run for so long. And so again, recruiting a nurse and additional support staff, that is a lofty goal, but I think maybe we think lofty. And perhaps consider reevaluating staff salaries as inflation is high. But again, if that passion can only kind of run on so long. And it's important to the sustainability of the clinic, I think, to keep the staff or to keep in mind the staff's well-being. And then we have that last one, kind of encouraging healthy practices through health education, kind of making that an integral part of clinic and outreach activities. And again, maybe that's like a difficult suggestion with 2 nurses and 1 clinical officer, and that right now that might be a little bit difficult to achieve, but kind of looking at targeting hygiene practices, demystifying harmful practices, and then also kind of encouraging men to support their wives' maternal well-being. So kind of in the realm of women's empowerment, but involving men in those conversations as well. And then lastly, for the teenage empowerment program, the recommendations here, producing or having some kind of standardized age-appropriate curriculum or manual for teaching. Right now it's kind of ad hoc, which is understandable. It's kind of on one of the nurses' volunteer time that she's going to the schools, but perhaps having some kind of standardized curriculum that kind of follows a set schedule of sorts, and that is kind of age or made for different age groups, and establishing a timeline for learning. We have here also establishing a school health club, so perhaps kind of using students as kind of peer educators as well and as peer points of contact. So if Nurse Rachel can't be there, you can go to so-and-so and they can kind of help you out, or like having kind of safe spaces within the schools and building those in peer educators. And then building a referral system where students can be easily referred to the clinic in the event of an illness, like having some maybe like point of contact at the school that kids feel like comfortable in getting referred to. If we're gonna educate on STIs and symptoms, et cetera, then making sure that we have kind of safe communication channel for students to be able to present themselves to the clinic. And then lastly, this effective counseling unit to not only give students a space to talk about reproductive health, but also on career counseling. I think that in the high school especially, there were, many students, I think, just didn't know what opportunities were available to them and didn't really know like where to go after high school or like what kind of opportunities existed. So whether that's having like a career day of some sort, or whether it's having somebody on site or on staff that kind of is able to provide that kind of space, I think would be a big value to these kids.
Yeah, I wanted to add something.
Yeah.
Yeah, it's also like very, very kind of funny, but consistent with what I see, like, because I've worked in Nigeria and some suburban areas. So when we ask the girls, so what would you do after school? Get married. It's crazy. So, and then the boys are like, I don't know, maybe find work, but we can't work without our certificates because we're paying a lot of money. So that I feel strongly that there's a need for counseling. I mean, if there's a way people, I still feel strongly about the alumni network, even if just holding like some career talk with these children. And they're always on, they have like Instagram, they have phones, so they're able to connect to the world. And just being able to have that one person speak to them, because they don't ask us that my friend just traveled to abroad and she's doing well. I'm like, are you sure? I don't even know what their friend is doing abroad, but in their mind, there's some sort of savior that will come take them as nurses and go abroad. So just being able to help shape them in the right direction would really go a long way. Yeah, and one more thing about the empowerment program is being like the reason why we're advocating heavily for the manual is because we have to be able to teach something that is consistent with the truth, because sometimes if you teach off your head, you are able to pass your biases, across to the students. So, but if you have like a curriculum that, even if you don't believe in what they're saying, but that it's been tested, that manual is very important because they are getting some things that that didn't go down well with us. So I think that having that is really very important.
Did you hear that there was there a teacher who had been a graduate of the program? But I had heard there was one teacher who had actually graduated from the high school. And I was going to teach there.
Was that at the primary school?
Oh, the primary school?
Teaching at the primary school, but graduated from the high school. I think the school's only been around for that decade.
2012.
Okay, thanks.
Yeah.
You had a question,
Well,
Don?
I was just gonna say, you might change the verb on that first bullet point from produce, because that feels really overwhelming. I mean, UNESCO has comprehensive sexual education curriculum, and most countries have adopted that, and adapted it, sorry.
Adapted,
And there's, life skills, so probably there's a good curriculum that exists in Kenya, and so not
The Kenya
recreating.
There is-
allowed.
There's even a guideline for adolescents and young
Yeah.
people. Also, the one which the party really worked on. So there's a lot of resources.
Yeah.
There's some resistance though.
Yeah, there is a lot of
Teaching.
resistance around comprehensive sexuality education because of the extent that it goes. But there's been like efforts to develop a curriculum for teaching sexual education in school. So it's there, but it's limited. But even if it's limited, it's better than nothing.
Yeah.
So there's been work.
And a lot of times, the name it's called life skills.
Sex, life
You know,
skills, yeah,
life
not even
skills,
working.
yeah.
Life skills. Yeah,
And
that'd be useful.
you might want to even tie your recommendation to, some of the things you brought up about norms, gender norms, because CSE really deals with that. And all the issues you brought up about empowerment and being able to say no to sex and things like that, or how to negotiate and consensual sex. And then I was gonna say something else. Oh, be careful about the peer mentorship. The literature on that's not so great as being an effective tool, and so you just want to maybe check the literature before you recommend something that's been shown not to be effective. Yeah.
Can I just ask how this piece ties into the clinic? So you said a nurse does this on their, so it's not an official component of the clinics and or it's just the nurse had the idea of doing this, and so the nurse developed this plan and is implementing it, or is it part of a larger?
So from what I asked the nurse, there was an issue of FGM in the community, teenage issues like teenage marriage and pregnancies. So the nurse, she's like, very proactive, decided to take it up on herself. So she took it to the director and said, I want to start this program.
Okay.
Yeah, so she started going to the schools by herself to teach them. Yeah, so it's not really like official.
Okay.
Yeah.
And we did have a student early on,
Yeah.
probably back in 2014 or 15, who went into the schools for her side of the project and was working on a curriculum because she had done the same as a Peace Corps volunteer somewhere else in Southern Africa. And so she had the skill set, and that's what she did as her project. These things don't necessarily last 5 or 10 years. And yes, Sarah?
Yeah, the first thing I wanted to say is really great work, Jacinta and Tara. Because I've never had.
If you guys aren't done, we keep.
Yeah.
Next slide is thank you. I wanted to say thank you to DGA Travel Opportunity, Dr. Kari Fakwa. She went with us to Maasai
I took
Land.
that picture.
Yeah, so we were trying to put your picture, but we didn't want to put your picture. I don't know if you like it, but thank you to Mr. Kakuta, the Merrueshi Clinic. In fact, we had elder brothers at the camp. They were like, "Have you eaten? Come out. Are you okay?" So we had a very great time. And then we got a lot of Kenyan friends and well wishers. We did everything you can think of in Kenya. So all thanks to Dr. Kari for the connection, and for all of you who are also here to hear from us. We appreciate you all. So
To recruit some more students. And back to you, Sarah.
Yeah.
oh yeah, sorry. So we have Rachel on the call. We asked her to actually join if she wants to speak for the nurse. To speak to us for 2 minutes or 1
I do know
minute.
we have another meeting in here in 5 minutes.
Oh,
so don't
okay.
forget Rachel. First,
She also warned that she might.
There we go.
Hello, how are you?
Hello.
How are you?
Welcome, Rachel.
Can you hear me?
Yes, we can.
How are you?
We're good. Do you want to say something?
Yeah, I was listening partly because I had an emergency. That was good. Thank you for everything. Thank you for support. And we are grateful to Carrie because she still brings you over every now and then. And
Try.
yeah, and we are happy that you guys are trying to do the manual of adolescents teaching or whatever sex education. That would be a standard thing. And I would really, really wish that it comes out because it will help the girls in there, actually even the primary school. I think I'm okay. I was listening and I'm happy. I've got her because I have a maternity lady. Is a mother in labor. See you later.
Okay.
That's
All
right.
right. Bye, Rachel.
It's midnight there, I think.
Yeah.
Thank you, Rachel. Thanks for all your great work.
Okay.
That's wonderful.
Thank you. Thank you for
All right,
support.
Yeah, so I wanted to say I've never seen any students do like what you have done. Like you're not from Kenya, but you've gone there and you know everything about that community. So you got immersed and I'm really impressed, really extremely impressed for you to know about the Maasai and what they do and how they live and some of the things that really affect them. I really applaud you and really congratulations. It's really great work. My comments were two. I think looking at this, there are many, many issues and many things that can be done as well. So it might be nice to probably follow this up with an action thing because there are things which can be done, things that do need that you can do, and there are things which can be done by others. Like a lot of these things are policy issues. So I don't think it's anything that you can do, but one of the things that you can do is to have an action and have some discussion. And I am happy to definitely work with the Kajiado County and, to institute anything. If there's anything that the government can do to support, because it's serving the people. And that's how governments work. If there's a need and there's something, then they'll say, okay, can we give drugs or something which which is not something, or maybe send staff or something. It's not a promise, but like I think engaging is good. The second thing is community. Like I don't know if there's been anything around community-based research and approaches with the community to actually address these questions. Like you're saying, the high school, but the community must have a say because it's in that community. So having, I would say, the opportunities here for students and opportunities for actual implementation and programs. So I can give specifics, but I would really be happy to keep this going, like this going. Maybe we should write an infrastructure grant or something for them. Like, but those are short term.
Do it again.
But we should long term. Like this is a it's not something which you can do with one.
And interestingly, Kakuta is now a member of parliament. He's one of maybe 2 Maasai in all of Kenya parliament. There are very few. But he's in government, and I think because he saw that as his way of trying to access more and do more for the people in this community. Because it's hard. It's hard to do a lot with little. I would say the total budget for the schools and the clinic and all this it's definitely less than 150,000 a year. And these are, you've seen this school, like that primary school where they feed all the kids and they have them all living there. It's probably 600. There are a lot of kids there. And so they do a lot with very little. But that's also why there are these challenges around just hiring more staff or giving someone a raise. It's not as easy to do when you just don't have the resources.
How does staff salaries compare to in the public sector?
So the nurses get paid 30,000 Kenyan shillings. Is that comparable?
Yeah, it's probably lower, but
Yeah.
Lower, wow.
Yeah, but the
But-
issue is that it hasn't for someone that's been there for 9 years, nothing has
changed.
But the support staff is the one that broke my heart. They get 5,000 Kenyan shillings monthly.
That is below the national.
Yeah,
That's not like
That's wrong
Yeah.
because they can't be
Yeah.
employed at that.
for like 5,000. They were literally crying to us, and I
Yeah,
couldn't do anything.
the 30,000 is what, 250 a month or something like that. So it's not.
But the support staff, and they work 24/7. Yeah,
And they
to
have
play.
one weekend off.
Yeah,
a
one
month.
weekend off. So there's no time to even go out to look for other things. Yeah.
It's been so
Okay, well,
good.
thank you guys
Thank you
very
so much. Thank
much.
everyone for joining.